Well, thank you all for coming out. I'm Demetra Antimisiaris. Everybody just calls me Dee. And I'm the director of the Fraser Polypharmacy and Medication Management Program at the University of Louisville. I'm also an adjunct professor in neurology. Now, to clarify, I'm not a Parkinson's expert, but I am a geriatrics pharmacist, right? That's been my whole career. I trained at UCLA in the 1980s in geriatric pharmacy, and you know, by default, you have to know a thing or two about Parkinson's medicines. A lot of what I'm presenting to you was taught to me by somebody who is a really good neurology pharmacist, and this is somebody who's out in Washington State. But anyways, the handout is based on her kind of summary of medicines, and we'll talk about that in a little bit. Actually, I'll take a copy so I know what I'm talking about. Did you want to get one of these? Okay. So today we're going to talk about Parkinson's, medication management, and on and off periods, and the importance of consistency and routine management. What do you guys think so far about medication management?
It's a mystery.
It is a mystery, right? It's very tricky. It's not helped by the current healthcare delivery system, which gives your doctor 15 minutes per patient. It's a huge, huge issue. And the Fraser Polypharmacy program started in the School of Medicine, and after 11 years, we moved it to the School of Public Health with a foot still in medicine, because you can't leave what you don't do. But after years of trying to just educate people better about medication management so that doctors could do better, nurses could do better, we realized that that isn't what's driving random medication use. What's driving it is the healthcare system and the way we deliver healthcare. You know, the healthcare system is driven by incentives and reimbursements. And you've probably heard that your physician has to see about 40 patients a day to help them keep the lights on. So what does that mean for complex medication management? At the moment, it means that, to be honest, you're kind of on your own, or at least you have to be a robust partner in your own medication management. And what I'm talking about is helping out your doctor when you do have those 15 to 30 minutes with them. And we'll talk about how to do that. So you all know all this statistical information that there are about 100,000 new cases of Parkinson's diagnosed every year. In the United States, about 3 million worldwide or more. It's growing because age is the biggest risk factor, and the whole population is aging. It's more common in men than women. I have no idea why. I don't know if you guys have heard anything, but that seems to be a fact. And if I look at my own family, yes, I think of my father and my brother, but none of the girls. So, the progression, as you're all familiar with, it has to do with kind of a prodromal or pre-diagnostic set of symptoms, including, you know, depression, REM sleep disturbances, hyposmia, you know, little impairment in smell, and constipation and behavior disorder. And then when at diagnosis, typically in the early stage, that's where the bradykinesia, the slow movements are more evident, rigidity, resting tremor, and other non-motor symptoms like restless leg syndrome, pain, fatigue, and apathy. What's interesting about restless leg syndrome is that pro-dopaminergic drugs, I don't mean Cinemat or levodopa-carbidopa, but like, you know, like Reprederol, which is used for Parkinson's, but it's also given to people with restless legs. But you can get restless legs from taking serotonergic drugs, like antidepressants, in high enough dose. As you augment serotonin, you decrease dopamine, because your dopamine producing cells are somewhat controlled by serotonin. So sometimes restless leg is really a side effect of medications, and it gets misdiagnosed and treated with Reprederol, right? So part of like things I go around trying to teach people is, well, we know that 10% of all Parkinson's diagnoses are actually misdiagnosed medication-induced movement disorders. So So that's one of the things with any medication that's psychoactive, like I said, antidepressants, aggressive antidepressant use, you have to be a little cautious because you have that inverse relationship with dopamine. And so is it the medicines or is it really Parkinson's? So that's another topic, but restless leg syndrome is oftentimes not quite treated correctly. As Parkinson's progresses and you get to like middle stage and late stage, that's where your on and off periods and motor fluctuations and dyskinesias become more apparent. And notice that that kind of aligns with slowing of the GI tract, the stomach and the intestines. Well, that makes it really hard for the medications to work as designed. So one of the main principles that I teach in my program of any drug, even to the undergraduates, is that drugs are designed to work under certain conditions. And when the FDA tests drugs, when they say empty stomach, they mean empty stomach, like an hour before eating or 2 or 3 hours after, and the drug is taken with like just a little water. So that makes a drug behave very differently than if it's taken on a full stomach or in somebody who's taking a drug that alters the acid level in your stomach. So what I mean is we have specifications. It's like a car. You have, recommendations and specifications, right? The car, per the manual, can drive, 80 miles an hour, but then we're out there driving at 200 miles an hour. It's the same with medications. Medications are designed to work under certain conditions, and those conditions change. So early in my career, the only choice we had for Parkinson's was carbidopa, levodopa, immediate release. That's it. The one that you take 4 or 5 times a day. You couldn't really count on that to behave very well when your GI tract is changing. But as you know, today we have other forms of medications, right? We have gels that can be given directly to the intestines. We have, inhaled rescue medicines. We didn't have all those just a short time ago. We also have a lot of meds that can be crushed and that can be dissolved. And it's because the drug companies are finally realizing that when you design a drug for normal oral administration under certain conditions, that really doesn't fly when you have Parkinson's, right? Because things change all the time. So the drugs are getting better. That's the good news. Later on in the disease progression, the on and off and the dyskinesias have more to do with progression of the change in the body and how that interacts with the drug. And the middle stage, the main thing is really how the stomach's working. So you've probably seen this diagram before. This is your normal nerve terminal where the dopamine, here's your nerve cells, and it transmits signals that way. And the dopamine would be those little blue circles, and they're packaged in what's called the vesicle. And when it's time to transmit, the vesicle releases the dopamine between the 2 nerve cells, and then the yellow thing there is the receptor that catches the dopamine, and then it perpetuates the signal. With Parkinson's, what happens is you have not only less dopamine being produced, but you also have less vesicles that are packaging dopamine. You have slower transmission, and your receptors, interesting thing about receptors, they up and down regulate depending on the chemical soup you give it. So the example that I try to teach the students is, how do people get depression and anxiety? Well, they're under terrible stress, they're under trauma, their adrenals put out hormones that cause like overactivity of dopamine, norepinephrine, and it keeps like pounding those receptors. And those receptors are like, stop. So the receptors become less sensitive and they will become less in number eventually. So that's why you get tolerance, right? If you drink a lot of alcohol, eventually you can drink a lot of alcohol because your receptors are not reacting to it anymore. So I bring that up because that's not the main thing with dopamine treatment, but you've probably heard that the longer you're taking levodopa, carbidopa, it's a risk factor for having more on and off, right? And part of that has something to do with stimulation of the receptors, but it's not everything. So basically, remember, the chemical soup you give a cell will make the cell react. And there's some very interesting epigenetic data coming out that how environment impacts physiology along those mechanisms. It's that up and down regulation of the receptor is controlled by what? By the cell genes. And it's a bidirectional relationship. And there's an interesting article in Discover magazine that asks the question, do we inherit grandma stress? And when you think about it, yeah, you know, I mean, if you have a very stressful living environment, it eventually will theoretically, epigenetically, change your DNA through these chemical mechanisms. So I know it's a little philosophical for this talk, but that's kind of how I'm wired, sorry. I want to know the big picture. Okay, so the mainstay of how we treat Parkinson's is we use levodopa-carbidopa. And I'm sure you've seen this before, but I thought, you know, it helps us talk about it. What you have is, let's see, is this going to work here, this pointer? Yeah, good, okay. So we give levodopa along with carbidopa because levodopa alone can't cross into the brain through the blood-brain barrier. It'll get destroyed by this enzyme, and carbidopa kind of suppresses that enzyme, but when it's in when the drug's in your blood, so that it can cross into your brain without getting dissolved. This carbidopa, unfortunately, does not go into the brain, so that enzyme will eventually start taking it apart. But that's kind of what we want it to do in the brain, because then it becomes dopamine. In the blood, levodopa can get degraded to 3-O-methyl-dopa. And that's where your entacapone and opicapone come in, because that suppresses that enzyme. And so the whole goal is to keep the levodopa intact before it goes into the brain, so that it can go into the brain. Once it goes into the brain, you know, like I said, that enzyme that carbidopa suppresses in the blood allows it to turn into dopamine in the brain. Entacapone and opicapone don't go into the brain. So we can't do much about it's somewhat degrading in the brain before it becomes dopamine. We did have a drug called tocopone that does go into the brain. It's pretty effective. The only thing is it causes liver damage if you're not paying good attention. And so people don't use it that much. It's not super safe. The other way that we can keep the dopamine levels high once the L-dopa has converted is to give what we call monoamine oxidase B inhibitors. So monoamine oxidase also degrades dopamine, and that would be like your selegiline, razagiline, and safinamide. And those basically, they don't directly make dopamine, but they stop the dopamine from degrading. So you can kind of see that the mainstay of treatment is levodopa-carbidopa and using medicines to help it get into the brain. And then once it gets into the brain, using medicines to help it not degrade, to kind of up your dopamine levels. But early on, when in early Parkinson's, we don't use all these together, as you know probably from experience, that you use one of them, and then you go as long as you can on one of them, and then if you need more, then you add another. And the reason is if you just go like shotgun at it, then you really can't fine-tune the treatment later on when things get more complicated. So there's pros and cons about levodopa. It has a very short half-life. That's why you have to take it like 4 or 5 times a day. And as mentioned, the absorption of it from the blood to the brain is tricky, but that's kind of taken care of chemically. But furthermore, the absorption of it from the stomach when you take it has to be not in the stomach, but in your small intestine, in the duodenum, right past the stomach. So if your stomach is slowing down or it's got a lot of food in it, it takes some time to get to the next step, right, to the duodenum. So those are some of the things that kind of hang things up. Also, it requires active transport. So here's your stomach or your duodenal lining and your cells. It has to be taken across the lining by an active transporter, and that active transporter also transports amino acids or proteins. So you probably know, like, you're not supposed to take your levodopa carbidopa with a protein meal. The reason is it will preferably bind those active transports and make it so you can't absorb your levodopa carbidopa. So you want to, separate it from a protein meal. I also want to point out that those COMT inhibitors, entacapone and opicapone, when you read the fine print on these drugs, it's interesting what you find out. If you take it with food, you'll absorb about 60% less than if you take it on an empty stomach. So bottom line is, the more you can take these drugs on an empty stomach, the better they're going to work. The opicapone and entacapone, it's a different reason than this, but food impairs its absorption. So there's those kind of problems. The good thing about levodopa and carbidopa is it's really safe. It's really safe. I mean, you're not gonna, burn out your pancreas. You're not gonna get gangrene from it. I mean, it's been around a long time. It has side effects. It can cause dyskinesias if too high of a dose. It can cause, vivid dreams, and etc. But it's pretty safe. It has a lot of different dosage forms too, and that's on your handout. We'll talk about that. So in summary, we talked about how levodopa carbidopa is absorbed and that the conditions have to be just right. Problem is that as Parkinson's progresses, the conditions become not just right. The stomach slows down. Maybe it was taken with protein, and so you're taking the dose and it's not really getting absorbed very well. Furthermore, in the small intestine, you have to have that active transport, right? So you want to make sure that there's no competition. And so here's your dose, you take it, and you're taking the same dose every day, and then 6 months later, your GI tract is functioning a little different. So you take that first dose, and it's just sitting in your stomach. It's not really going anywhere. And then you take your other dose, and you're like, well, that's funny, it's not working. And then all of a sudden it works, except it works later, or it works off schedule. That's because something's changing in here. We also found that there are some bacteria that can impair levodopa absorption. And this is kind of like something that is hard to do anything about. And the neurologists are studying it now, but we do know that there are some bacteria in the gut flora, you've probably heard of that metabolize levodopa so that it gets metabolized before it even gets absorbed. One of them is H. pylori. H. pylori is the one that causes like stomach ulcers and infections and stuff. That's actually kind of treatable, but that's for a kind of a esoteric, strong, like neuro expert clinic to take care of. But what we can take care of on an everyday basis is paying attention to when we take a dose, when it's working or when it's not working. Because then that helps tell the tale of what's going on here. So wearing off and levodopa-induced dyskinesias are common and almost inevitable as disease progresses. Higher individual doses of levodopa are associated with wearing off and dyskinesias. Like I said, it might have to do with how much you expose the cell to dopamine, but also it might be just an artifact of population studies where, oh yeah, people with higher doses have more on and off. Well, of course, because they're taking a higher dose because the disease has progressed further. Altered neuronal circuitry and firing is another big reason why we get dyskinesias and on and off. So motor complications are how the medication's absorbed and how it's working. It's how our physiology is changing over time, and we start losing dopamine terminals, and you start losing recycling. Remember the little vesicles that store it? And that results in kind of a pulsatile dopamine stimulation. Same thing, have you heard of that drug called Nuplazid? For like hallucinations and dementia that comes with Parkinson's. It's a serotonin, it slows serotonin, and you're thinking, what does that have to do with dopamine? But it turns out that any of the neurodegenerative conditions, Parkinson's is probably the most visible, but as you start losing these nerve terminals, it's kind of like, you know, like when you become diabetic, you start having a hypoglycemia. It's because like your cells are trying and trying and trying, and you get a pulse of whatever those cells make, and then sometimes you get none. And that's kind of what happens as your nerves are degenerating, and that includes your serotonin nerves, right? It's not just your dopamine, it's your serotonin nerves too. So you get this kind of weird pulsatile dopamine from your body that doesn't come out consistently. And so you're taking a dose, and some days your natural dopamine's real high, and then guess what? You get dyskinesia, you get nausea, you get, you know, hallucinations. But some days it's really low, and you take your dose, and guess what? The dose helps. Or maybe it's not enough of a dose and it doesn't quite help. So that's why paying attention to when you dose and what your symptoms are, and I'm gonna recommend keeping a log, and this is where we have to work with the health system we have. If you can bring your doctor a log of what you ate, what you took, and how you felt, periodically throughout the day, it would really help them. Because that way they could look at it and figure out, oh yeah, you know, maybe we need to adjust X, Y, and Z, because at this time of day and that time of day, we're getting freezing or we're getting, you know, on or off. So as the disease progresses, you can take a dose and you can get, like I said, it can work, it can not work, or you can get a side effect like dyskinesia. So basically the anti-Parkinson's therapeutic approach includes single medication use in the early stages, reserving carbidopa, levodopa, plus other medicines to manage dyskinesias or off periods in later stages. We also have these amazing rescue medicines that we did not have not too long ago. These are really fantastic. One of the problems we're having with them though, you might have noticed, is insurance coverage, right? It's not consistent across the board, and that's a whole other political battle, and why we're in the School of Public Health, to see if we can fight that battle. But you've got your apomorphine subcutaneous pen, kind of like a needle, or a sublingual film. And apomorphine is a direct dopamine agonist, meaning it stimulates those receptors. Instead of dopamine, it stimulates it itself. So on top of the dopamine you have in your body or through levodopa, it stimulates, it adds to it basically. You also have levodopa inhalation powder. Does anybody use that?
Yeah.
Curious, what do you think about it?
It didn't work for him.
It's kind of hard to use, right?
Yeah.
Well, they changed how to use it too, based on how you inhale and when you inhale is what it is.
Yeah, it's not easy, is it?
Yeah, well, but they changed how you do it too, because in the beginning when they first put it out, it was like just.
The game you see,
Yeah,
it.
Really?
Yeah, it's different now.
Now it's 2 of them.
Yeah.
And you have to load it right before you use it, right? You can't preload it,
No,
Yeah.
right? Which is kind of a bummer, because that means probably someone has to be there with you, you know, loading.
Unless you have samples, they're already preloaded, some of the samples.
Are they?
Yeah.
Okay, so that's a good thing then.
It didn't work for him, but he gave his samples to someone else and it worked for them.
Interesting.
Yeah, we know several people in our group that use it and absolutely love it for whenever they do need it. But then we had also seen a new, or we've gotten information on a new way of that it would be delivered. So a new inhaler. So.
And it's an improvement over this.
Yeah, it's going through approval right now.
Okay. So that's the good news, is they're really kind of upping the game. You know, back in the day when all we had was cinnamon. That's good to hear. Yeah, and actually, if the levodopa inhaled didn't work for you, did you try the apomorphine? Did it work?
The needle?
Yeah, the needle.
Yeah, it did that too. and I got a big old bruise on my stomach.
Yeah.
Bummer. Did you try the film? They have like a, you put it on your tongue kind of thing?
No.
Right,
That might be,
I try everything.
I know, so anyways, we've got those, and, so what are the population-based, what do we observe are the highest risk factors for, off periods? It's severity of disease, but more duration of disease, like the longer you have it. The treatment duration, the dose that's being taken, and younger onset. So the response to levodopa, as mentioned, changes over time. In the early stage, it's called the honeymoon stage. Usually, you have a pretty effective control with levodopa, carbidopa, and sometimes, like let's say you're on a 4 times a day regimen, sometimes you can take it 3 times a day and it still works because you've got enough dopamine still, circulating around that when you add this, it brings the level up high enough and it's very predictable, right? But then in the middle stage, like after you've taken carbidopa, levodopa for about 9 years or so, you start getting the kind of cycling and the on and off happens more, and the dyskinesias because of the change in the terminals, and then you add the medications to it and it just doesn't work the same. It's not as predictable.
I got a question.
Yes.
I've had the DBS surgery.
Oh, have you? Good.
And,
Yeah.
And more, I could go without the carbidopa, levodopa, and not notice any difference.
Really?
For a
Because
while,
of
for a
DBS?
while it affected that.
Same thing here too.
Oh,
I went 4 years without taking anything.
really? With the
It's
DBS?
amazing, yeah.
Yeah.
I remember without none, I started with 8, had the surgery, I didn't take any for
Several years.
And then I'm back up to 5.
You know, you're back at the beginning again.
Yeah.
So it's almost like a reset.
It
sort of.
is, it is.
Kind of like putting it on pause for a few years, and then eventually, it comes back. I just recently resumed taking one of the little yellow pills.
After taking a lot before and then
Oh,
the
yeah.
surgery.
I took a lot, then I had the surgery, then I didn't take any. And just recently, I started taking one of the little yellow pills each day when I first get up. Kinda
Fantastic. Yeah, in the
kickstart
morning.
me.
Yeah.
Yeah, stomach's empty.
Yeah, and plus the tank's empty, right? You know what I mean? Like
Right.
you've been sleeping overnight, so
Right.
that's fantastic. No, I'm glad to hear that. I don't know, I just think that it's funny because we used to think that there wasn't anything you could do for neurology patients in general, but now there's a lot of technology coming out that pretty amazing. Yeah, same with spinal cord injuries too. They're having a lot of amazing technology. So I'm optimistic. Maybe us pharmacists will be put out of a job someday. That'd be great. Because after a whole career, it's like, let's do something more exciting than just looking at all these chemicals. Okay, so then, again, latter, the dyskinesias and the off periods become more and more, and that's just really where you have to really fine tune it, because sometimes when you up a dose, it doesn't take much to get a dyskinesia, right? Because there's no homeostasis, there's no buffering of the dopamine in your own body anymore, and that's where the dosing becomes really hard. So in the early stages, I mentioned we use one product usually, and usually they'll start with an MAO inhibitor like selegiline or misagiline, and there's the oral dopamine receptor agonist, meaning the ones like apomorphine, but not as strong, like ropenetrol. Those are the dopamine drugs. And then amantadine, we don't really use it. It has some benefit for tremor, but that's about it. It's usually used in younger people, like people who have early onset. And then there's the carbidopa levodopa. There's a carbidopa levodopa sparing approach where oftentimes they'll try to not use that until later. It was again theorized that because the longer you use it, the more your cells become kind of used to it. That theory has been kind of debated and nobody's really sure right now. But they do know that duration on levodopa carbidopa is associated with more on and off. So they'll try to manage it in the early stages with the MAO inhibitors or the dopamine 2 receptor agonists, like Nupro and those kind. Later on, it's mainly carbidopa, levodopa, and you might add the long-acting kind to cover those fluctuations. And then in late stages, it's polypharmacy. Like you just use a lot of different things together, or you get surgery. Yeah, that's really good news. I'm glad to hear that. So this is where I'm saying keeping a log is super important. If you can recognize the pattern of motor symptoms, and you can help your doctor recognize that pattern, then adjustments can be made. So wearing off and morning wearing off, or what's called morning off, they're the same thing basically, except morning off is just your gas tank's empty, right? You don't have any dopamine left because you've been sleeping for 8 hours and your last dose was before you went to sleep. And basically, it's because carbidopa, levodopa has a short half-life, and you have diminished dopamine storage in your body, and there's usually some kind of gap there. You either need a higher dose, or you need it more frequently, or you need to look at the conditions which it's being absorbed. Delayed on and dose failure. Those are almost entirely because of gastrointestinal slowing. And there's ways around that. And we'll talk about that in a minute. And then there's random on and off, which is the later stage where you get that pulsatile dopamine in your body, and then it gets really hard to coordinate the dopamine doses with what's going on in your body. So basically, the wearing off, the key there, and the morning off is that you can tell when it's going to happen predictably, right? That's the key. With delayed on and dose failure, it's not as predictable. And then with random on and off, it's unpredictable. That helps your doctors know what to do. So with wearing off, you just really adjust the daily treatment. You don't really add new stuff. You know, you usually don't need a rescue drug like apomorphine or the inhaled levodopa. The key there is to go through a checklist and say, okay, am I taking my levodopa, carbidopa separate from a protein meal? Has my dose been adjusted, or is the dosing interval needing adjustment, or has it been a long time? If none of those help, then it's time to think about adding something to slow the breakdown of dopamine, like an MAO inhibitor, like selegiline, or a COMT, or something like that. Or you can add a dopamine agonist, like reprendrol. Wearing off later on, that's when you start using your rescue meds to help. And then you can consider surgical procedures. There's the DBS that we talked about. There's also the possibility of instilling a tube so that you can use levodopa carbidopa gel and totally bypass the stomach problem. And that usually works pretty well. Morning off is, like we said, there's nothing on board because you haven't taken anything since like 10 p.m., right? And so a couple things you can do is crush or chew a carbidopa levodopa first thing in the morning. It's important to crush or chew it so that it'll get absorbed faster. Also, if you take it with a carbonated drink, that helps. The reason is it goes in your stomach and it kind of dissolves things better, but it also irritates your stomach, which moves things along a little better. So crush or chew and take it with a carbonated drink first thing in the morning. You can also give an extra dose of carbidopa levodopa during the night if you're somebody who happens to get up at night or somebody can help you get some. A controlled sustained release tablet could be given at bedtime. And in your handout, you see that the first page is all the different carbidopa levodopas, right? There's immediate release, there's oral dissolving ODT tablet. Those are the ones that you could crush, but the main thing here is you have to swallow them. And then there's your extended release, which can be given late at night, and that could last you longer into the morning. And then there's the intestinal gel, and there's the rescue powder. And there's a really new product that's kind of nice. You've probably seen it. It's a scored tablet that you can break into smaller doses. So, you know, the carbidopa levodopa is usually 25 over 100, 25 milligrams. If somebody's having an off period and you add an extra dose, you risk getting what? Yeah. So this new kind of tablet where you can kind of titrate the dose with just a little bit more can make it so that you can get the benefit and avoid the dyskinesia of adding a whole nother 25 milligrams. So that's kind of a handy option. Okay, you could add a COMT or MAO inhibitor or surgery. But there's a lot of things that can be done for morning off before you decide to add surgery. Okay, what about delayed on and dose failure? These are lumped together because they're because of the same thing. Usually it has to do with gastroparesis, slowing of the GI tract, a high protein diet without separating the drug, or the gut bacteria. So the main thing here is to make sure that people have a rescue drug and use it when needed, and then separate from high protein. So some people recommend using what they call prokinetics to help gastric emptying, but you gotta be really careful with those. Some of those are anti-dopamine, like metoclopramide. You have to stay far away from that kind of drug. It helps your GI motility, help things move along, but it would really freeze a person up. So there's alternates, and they're testing a whole bunch of new ones right now actively. But I would say helping gastric emptying right now is not a reality, except maybe take a soda with your meds.
Okay, when you're talking about that, are you talking about things you might take for like constipation?
No.
You're not talking about probiotics or?
Oh, I see what you're saying. Yeah, the question is that like something you would take for constipation? No, it's not. So your stomach motility is not really affected as much by constipation meds. You could take them, but you'd be cramping all the time. You'd get diarrhea, and you might not get any of the dose at all. You know what I mean? Like it might go too quickly. There are drugs that, like in diabetes, you get a lot of the same thing, where your gastric tract slows down, and they'll give people metoclopramide, which is anti-dopamine, and it helps move things, but it's not extreme, kind of like constipation medicines. The other thing is, if you were to take constipation medicines all the time, you could get what's called flaccid paralysis. Like if you stimulate the gut all the time, eventually it stops working, and that's a worse situation. So they're working on trying to figure out what to do about that. But
okay, so something like Miralax or something like that is not a problem.
The Miralax is not so bad. The downside of it is that you have to separate your drugs from it, because it can it's polyethylene glycol, and it can kind of coat your meds, and you won't absorb them. Any med, not just these. But people don't realize you have to separate Miralax from all your meds for about an hour after you take it or more. So that can make it kind of hard. Yeah.
So if you increase your fiber though, there should not be an issue. Is
Right.
that correct?
Right. Metamucil, increasing your fiber, that can help. That can pull more liquid into your intestines, which kind of, it's called a bulk forming agent. So if you increase the bulk in your intestines, you actually stimulate it to evacuate, right? But the problem comes when you have neurological impairment in that system, and your body doesn't know it. Like you can keep bulking and bulking, and it doesn't know to go into action. So it's really a very tricky problem, and the only real way that we get around it, if it gets extreme, is doing the surgery to use the gel. Or, in rescue situations, there's that trick of crushing the medicine and taking it with a soda, like with a carbonate. Stool softeners are a little bit like Miralax in the sense that they coat the intestine. And so the risk there is that it might make your medicines not work as well. So it's not a fun situation at all. That said, exercise helps. Yeah.
What's a high protein meal? What is it, what number of grams classifies as a high protein meal?
I think any protein, because that active transport system, it grabs onto amino acids. So like the best thing to do is to, I know it's tricky when you're taking like 5 times a day, right? Taking meds 5 times a day. Minimize the protein that you take, or have a time of the day when you can eat a sufficient amount of protein for the day.
And how much time should elapse?
Quite a bit, like an hour before or 2 hours after your dose. Because that's how long it takes for medicines to transport through your stomach, basically. I wish I had a good answer for you on defining a protein, high protein, but.
So if you every once in a while drink one of these shakes, it's got 30 grams in it, you probably shouldn't be doing that.
Except do it like maybe before you go to bed, right? After you've taken your meds for a couple hours. Well, that's kind of not practical, but you know, I really don't know how you would do that.
Or you would drink it like an hour before you would take your meds, an hour or more before you know, and then you take your med.
Yeah, your best bet is to do it early. But then what if you can't swallow too good? You know, that's where it gets tricky. Yeah.
I have a comment about the carbonation.
Yes.
Carbonation affects your urinary tract though. If you have urinary issues,
it makes you feel like you've got to go.
All
right?
the time, yeah. So that's something
that's a good point. Yep.
So would probiotics and prebiotics work?
Probiotics mainly help keep your GI flora, you know, the different healthy. Doesn't do much for kinetics, like how the muscles work. Just like in your bladder system, your GI system is super complicated, right? It's the muscle itself, it's the connection from your brain to the muscles. When I say muscles, I mean the GI tract. It's what you eat, it's, you know, whether you exercise and move, but the bacteria, the probiotics, doesn't do much except I don't want to discourage anybody from taking them, because, you know, we're starting to find that our GI health it profoundly influences our wellness over the long haul. I mean, I'm not a neurologist again, but I read about this stuff. I read about dementia a lot, and you know, there's a thought that our environment is what's triggering a lot of these conditions. And the biggest exposure of your body to the environment is your GI tract, right? And so when you start getting imbalances, like I study how those bacterias metabolize drugs, and we've looked at diets that are heavy in meat, diets that are heavy in plant, etc. It changes the type of bacteria is in your gut, and it can change the way your drugs are metabolized severely. So it's super important to keep a healthy GI, and probiotics are a good thing. Can't hurt, right?
So, say we go on a vegetarian diet. Okay. Just keep a journal of how it reacts to our medication as we go on. And it seems it makes a difference from doing a high protein like keto diet or something like that.
Yeah.
Right?
Yep, totally makes sense.
Okay.
Now you have to remember that you have to look at it within like a short time period, right?
What would be a time period where you would?
Yeah, like a couple of months. Like if you were to go vegetarian,
yeah,
and then a year later you're like, well, actually I've got more off periods. Well, it could be because the medicine's working just as well, but the disease is progressing. See what I'm saying? So you want to look right when you start, see if it makes a difference in how your medicines work.
Okay.
Yeah. But you still have to get proteins.
Yeah.
Right? So what do we do if we want to bypass the stomach? We actually have quite a few ways nowadays. We've got the pens that we talked about. We have also an apomorphine pump. That's a rescue pump. We have a carbidopa-levodopa pump. That's possible. We have a rotigotine patch. That's a dopamine stimulant patch. We have sublingual, like I mentioned, of the apomorphine. We have selegiline oral dissolving tablets. So oral dissolving tablets can be put into liquid, and then kind of taken, swallowed, and that helps absorption. We have levodopa powder, and then we have the levodopa carbidopa gel. So these are all kind of recent developments, which is a nice thing to have.
So the recent developments, how is the insurance companies okaying that or not? That's
Yeah, it's so random, right? Because everybody has such different insurance. You know, usually a neuro clinic is really good at getting those prior authorizations done. And last case scenario, if you can call the company and say, hey, I'm not covered, but I want to, you know, my doctor wants me to use the drug, they have ways to help people get covered for free.
from like grants and things like that?
Yeah, they have, it's called prescription assistance programs, and it's directly from the company. But, hey, you know, what's that? Prescription assistant programs. There's even a website of prescription assistance programs.
There's a company in Florida that does it, but I use the needle.
Oh, yeah,
And I called up, see if I qualified. I didn't think I qualified for the time, maybe $1 million. I thought I would, good. And 2 minutes later, they called me, see, qualified.
You qualify.
That's a company in Florida, right?
Yeah,
Was it a prescription assistance company? I'll bet.
yeah.
When we call, they said, call this number, and we think you'll be approved with this. Okay.
Fantastic.
So we call the number, and yes or no.
There you go. I mean, it's unfortunate. What's that?
It's very expensive.
The pen?
Yeah.
The pen?
Yeah, by your slides, so that you pay for it by yourself, like $10,000 a month.
Yeah, and that goes for any medication. Like you can always call the maker, the pharmaceutical company for any medication if it was too expensive or not covered or anything, because they're given millions of dollars from the government to provide these services. But if you leave it up to them, you'll never know about it.
Yeah, it's a secret.
That's the thing. And the healthcare system, unfortunately, you know, theoretically, you would think maybe a case manager could do it for you, but they just don't have the time.
I have a little question. Now, all this we're talking about, seems like there's a separation between not having DBS and having DBS.
There is.
So I'm like, not sure whether to take the right dosage or the right amount.
That's right. All the data that we have is, at least in our pharmacy world, is like pre-DBSs. And the whole goal is to try to avoid surgery, but then there, like you said, there comes a point where you almost can't. And the surgery really helps. But no, I don't pretend to know anything about how these drugs work when you have DBS. I don't really know.
Now, also, the Requit, I take the Requit for the rest of the symptoms, which is worse than the Parkinson's.
You mean because of the side effects?
No, these symptoms of having
Oh, the restless legs? Yeah.
Kick all the time, you know. I don't like it. I don't like it at all. But the Requit really helps.
Does it?
But does that affect, if you take the same time as the Cinemet, does that help?
Yeah, yeah, it should.
Yeah, I take the same time and it seems to work.
It does go into the brain pretty easily, and it definitely helps it doesn't help your dopamine levels, it stimulates your dopamine cells. So, yeah. Have you tried those leg things, have you seen them for restless legs? They're used by athletes, and there's kind of almost like a calf sleeve that you put on, and it blows up and it puts pressure, and it seems to help for some people. I don't know.
I've seen them, but I haven't used it.
Yeah, they're actually, you know what's crazy? I think I saw those over the counter nowadays. It used to be only experimental, but people, you know, it's a fad.
Well, what do they call it?
Hey, you know what? Have you pictured those things?
We bought some that were like, they kind of Velcro around your leg there, and it lets
Yes.
the knee open so you can bend the knee.
And they blow up.
It was part of one of these PBS morning deals that they do, and we bought the thing. I bought it for Jim.
Yeah.
And it came, and he put it on, and he said, it was like cutting off circulation, it was so strong.
Oh, it was really
He
tiny.
said,
Yeah, they're compression sleeves like
Oh,
that, and then you know if one blows up, like I haven't seen the portable ones like that, but that sounds like more of a pneumatic, like almost a portable pneumatic, if it blows up. Because like you have the pneumatic machines that you can put your legs in, and it compresses and decompresses, to circulate.
That's what
That's usually in the
it helps your circulation somehow.
And they have those now that you can just buy from companies, just like to use at home now.
They do the same thing.
Things that, they strap you into them and
To,
they pull all night long,
to make sure that you're not just static.
Your blood clots.
Yeah, the staticness is dangerous.
But if they only go to your knees usually.
Is restless leg syndrome, what exactly that causes that?
Dopamine imbalance. So, remember I was saying that, like, if you take a lot of serotonin antidepressants, sometimes, or antipsychotics, all of those have kind of an artificial effect of decreasing your dopamine, like aside from Parkinson's, even if you don't have Parkinson's. And sometimes you'll see people who are sitting at the desk and they're just kind of going like this and they can't sit still. And it's kind of hard to tell the difference between restlessness, like restlessness that comes from your restless inside, or that it's you have to move or else you don't feel good. That's called akathisia. And that is due to dopamine deficiency caused by that kind of serotonin imbalance. But any kind of dopamine deficiency will cause restless legs. So, what's that?
Usually in one part of the body, like that thigh.
Oh, only one part? I would think it's probably more related to Parkinson's than anything else, than like your other kind of restless leg that people get. Another thing that causes restless leg is iron deficiency. So you might check your iron levels.
But you have to be careful with your protein levels at the same time.
True. You can take an iron tablet, but those are constipating, so I don't know. I'll tell you, can't win, it's terrible.
Are you gonna talk any about supplements? Any supplements or anything like that? No? Okay.
Because I, to my knowledge, don't know that they do anything for on or off.
Okay.
I'm not sure.
Okay.
So, like I said, random on and off, that's where we just throw everything at it. We use a lot of different things together. So let's take a look at Mr. Movie. And he was diagnosed 5 years ago, and he comes to the clinic to monitor his symptoms every 6 months. And he's got high blood pressure, high cholesterol, type 2 diabetes, he gets insomnia, and he gets migraines. Here's his medications. And he's taking, medicines for his blood pressure, for his diabetes guideline, and his cholesterol. Glipizide and metformin are for diabetes, levodopa, carbidopa. He's taking tolterodine for overactive bladder. He's taking ginkgo and NyQuil, and he takes as needed migraines medicines, plus anti-nauseants. He's mentioned that he's feeling tired and forgetful, and he thinks his insomnia is worsening. So, looking at his medicines, can you think of any of those medicines that might be causing him to feel tired and forgetful?
Too many of them.
Too many of them. Yeah, true.
Maybe the diabetes, too much diabetes medicine.
Yeah, if his sugar's going too low, right? Yeah.
The NyQuil.
Yeah, NyQuil.
Yeah, NyQuil, right? Anybody who's taken the NyQuil knows that you'll wake up pretty foggy in the morning, right? So the first thing we can do for him is we can just not do the NyQuil anymore and see if that improves his memory. Ginkgo has been shown not to help memory at all. All it does is thin your blood and make you have a higher risk of bleeding. So that's no good. Tolterodine, the bladder medicine, is also kind of like NyQuil, but it's designed not to cross into the brain. The problem is, as you get older, your blood-brain barrier gets weaker. So it could be causing him to be kind of tired and forgetful. And he's got overactive bladder. It's not unusual with Parkinson's to get that, of course, because look at the complexity of how the bladder behaves, right? It requires norepinephrine, acetylcholine, all these different neurotransmitters to work just perfect so that your bladder can empty. And then down there at the end, if you've got prostate overgrowing around there, It tightens up the sphincter using an alpha receptor, so it's very, very complicated and not uncommon to have overactive bladder. Most of the signals are controlled by dopamine from the brain. So we've got these very strongly anticholinergic drugs, that means like Benadryl or NyQuil, that are used to treat the bladder. They relax the bladder, and they can cross into the brain, and he's taking tolterodine. So we're gonna try taking that off because studies show that timed toileting, hard as it may be to do, is more effective than the medicines. Most people go off the bladder medicines within about 45 days because they can't tolerate the side effects, the mental clouding, the dry mouth, etc. So time toileting just means that whether you feel like you've got to go or not, try to go every few hours. Take yourself to the bathroom every few hours. And that helps empty your bladder and keep it empty. So the other problem we have in bladder is that, like, when you empty your bladder, if your bladder is too relaxed, maybe because you're taking tolterodine or some bladder drug, it's not going to empty fully, which means that it's going to fill up faster and overfill quicker. So that's why timed toileting works so much better. You just frequently empty your bladder, and that way you don't have that residual, and then more comes in, and then it gets more and more and more. So that's really what worked for this patient. The other option, we have to avoid pretty much any drug in that class because it causes you to be forgetful and tired. But an option might be Vigron. Anybody seen that drug? That drug works in a kind of a novel way, and it can really help the bladder problem. So now he's come back 6 months later, and he's experiencing worsening stiffness, arresting tremor, gait freezing, anxiety and sweating about 25 minutes before his next dose of levodopa-carbidopa. And he experiences a brief and slight dyskinesia right before bedtime. So this is the kind of stuff you want to keep in a journal, right? Because this helps the doctor figure out what's going on. He's taking levodopa-carbidopa 25/100 4 times a day, and he takes opicapone at 50 milligrams in the evening. Okay, so we know that what's happening with him is a mixture of these factors, and the clinical course may change in 6 months, but unlikely, maybe more like a year. The medication class he's taking affects things, and then it could be one of these problems: delayed on, dose failure, unexpected off, wearing off. So what do you guys think it is with him? You think he's got unexpected off? No, it's 25 minutes, right, before the next dose. So it's predictable. If it's predictable, it's either what? Wearing off. That's right. It's wearing off. Yay! You got it. It's wearing off. Good job. So it's predictable. It's either wearing off or it's morning akinesia if it's predictable. So if it's predictable, it's fixable, right? Well, most things are fixable, but you just have to know the pattern. So he does not take his meds with a high protein meal. He needs probably either an adjustment in his carbidopa-levodopa, or we need to add either a COMT or a MAOB, or we need to add a dopamine, right? But we don't really want to add new stuff if we can titrate what's existing to a better dose. So he's already got a COMT, he's taking opicapone. So how about if we add, what, amantadine?
Why don't you just increase the dosage of
Yeah, that's the best choice. Yeah. So that means we should either give him another 25/100, or we should give him one of those kind that you break and you get small doses. Which one do you think?
Small dose.
Small dose.
Yeah,
Yes.
small. That's right. Because he gets a little bit of dyskinesia, right? And he takes a COMT inhibitor in the evening. So that tells you that his dopamine dose is not really that deficient. Like if you were to add 25 or 100, he would get probably dyskinesias more often. So just a tiny little bit using this drug. Is anybody using that one? So it's a way to, rather than giving the whole 25 milligrams, you just break little bits and you see what works. And so it's a way also to stop increasing the dose, which has been known to increase off and on. So yeah, that's what you would do for this guy.
How do you say the name of that?
Oh, this is called Divvy. I know it's a weird name. DHIVY. I think it means like divvy it up. Yeah. It was created by a couple of docs actually who probably frustrated that if you give one more pill a day, you're gonna tip somebody over into dyskinesias instead of actually fixing the gap in the off. So.
When did it come on the market?
Pretty recent. I don't remember, but I know it's pretty new. Which I hate to say it means it's probably not covered very well, you know, by insurance, but it's
But you call that maker.
exactly. Yeah.
What about just cutting your levodopa?
You could. Yeah, you could. You could. Yeah, you could. Now, cutting a 25 down to that small would be a little hard, because what would happen? We did a study on. We had students cut meds in half, and it was all over the place.
They don't cut very well.
No, they don't.
Sliver off little pieces.
Yeah. Yeah. Okay, so basically the main thing is that when you have on and off periods, you have to remember that it's a sum of a lot of different boxes to check. And the more you can help your doctor check the boxes to make a more informed decision, the better. So if you could keep like a diary of what's going on and the conditions, that would really help. Now, the one thing that has been shown to help dementia, to help Parkinson's, is exercise. And I know it's hard to exercise when you have trouble moving, but it's super important. I mean, do what I say, not what I do, right? I mean, here I am in middle age and I know, well, actually not, I'm in my 60s, I need to exercise more, because it's the only thing that's been shown to like mitigate some of these progressive conditions. It's the only thing, study after study. It's fascinating.
It slows it down, it doesn't cure it, stop it, it slows it down. So I exercise all the time. And I think if I didn't, I would get.
Oh, I think, yeah, that's good. Do you make yourself like a point to?
I Zoom.
He does like 2 classes a day.
Fantastic, all right. Okay, my mom's 97, and she got into chair yoga, thankfully.
Yeah.
I think it's keeping her going, it's amazing.
That's what Zine and I did.
Do you?
Chair
Do you
yoga.
like
It's
it?
called Move It or Lose It class.
Move It or
But
Lose
it's
It.
actually chair yoga.
I love it. Is that on Zoom?
Yeah.
Yeah.
Oh, I love
And
that.
it's free in Zine.
Yeah.
She's a local dance instructor in Albany.
Oh,
She designed this program.
that's brilliant. Seriously, I mean, that probably pretty more effective than a lot of the treatments we have. Yeah, that's great. The other thing is, you know, as we get older, there comes a time when, you know, we need to think about what's important. And this is an important geriatric principle, which is in making any decision, you have to think about protecting your mind, protecting your mobility, your medications. You don't want to have too much polypharmacy. And really, decisions have to matter to the patient the most. Like, you have to have shared decision making. And if that's not happening, then you either have to demand it or get better care. And we have to balance that with multi-complexity. So here he is 82 years old, and he's still got a lot of medications. He's added now rasagiline because it's progressing. But what do you guys think about all his other medicines? Like, what happens when you aggressively manage diabetes when you get older? Metformin, when you get more hypoglycemic events, meaning, you know, more low sugar, because you're taking your regular regimen.
Not only that, but it messes with your intestinal system.
It messes with your intestinal system. It kills brain cells, actually. It does. Hypoglycemia has been linked to mechanisms of, you know, it hurts your brain cells. So there comes an age at which we need to think about time to benefit. Like you have to manage diabetes tightly, we call it, like keeping your sugar under control really aggressively for 10 years to benefit your kidneys and your eyes. So the question is, if you're 82, how aggressive do you want to be, right? So what we use is, we use kind of a prognostic approach where, you know, if somebody's like, we all know 80-year-olds who are climbing mountains, we all know 60-year-olds who can't get out of bed, right? So you can't apply the same approach to each individual. And so for people who have at least a 10-year life expectancy, we want to use the normal chronic disease guidelines like diabetes that you would in a younger person. But you might want to use some criteria to mitigate polypharmacy. There's something called the Beers criteria. I actually trained with Mark Beers, I'm just very fortunate. And there's a start and stop criteria. And it'll tell you medicines that might not be good for you and alternatives. So, but as far as anybody who's over 60 is very functional, we just manage them like normal. But if somebody has, you know, more impairments and their life expectancy is a little shorter, then we want to try to aggressively decrease the polypharmacy to avoid risks that maybe we can see, right? The less you take, the safer it is. But what about somebody who's frail, who really has a shorter life expectancy? So my mom, 97, I've peeled off all that I humanly can, and thankfully she has a good geriatrician. We've taken just about everything away, except for things that we know help. So this is kind of a table that shows time to benefit data that we have for intensive blood pressure control, cholesterol control, glycemic control, meaning diabetes, bisphosphonates, meaning for your bones, colorectal cancer screening, mammography, and mammography after breast cancer. And, you know, let's take my mom, right? I'm guessing her life expectancy is 1 to 2 more years, maybe. But 10 years ago, I was like, yeah, you better keep your blood pressure down or else. But if you're down here, the blood pressure medicines actually make her more liable to fall. So I'm like, okay, let's ease your target up to 160, 150 over 80 instead of trying to get you to 120, which causes you to have those lightheadedness things. Same with your glucose. So just keep in mind that, not now, but in the future, when you get really older, you don't really have to aggressively manage all of your chronic diseases. But those decisions have to be made with your doctor using evidence. And these are evidence-based decisions. There's a tool I meant to show you. See down in the corner called ePrognosis? It's an online website by University of California, San Francisco that has the prognostic tools, and it has a lot of these guidelines, like that's on there. It's a really handy thing to look at. Now, don't go into ePrognosis and plug in your information and get scared. Because that's the problem with ePrognosis. You know, oh, you've got a 50% chance of dying in the next year. Well, that's a population. That doesn't mean you, exactly you. So you gotta keep that in mind. Okay, sorry for the super long talk, you guys, but it's a complicated topic. So thank you so much for your time.